The first part of the lecture will be talking about diabetic retinopathy, so we'll get right into it. So I wanted to discuss a little bit about all the things that diabetes can do to the eyes, and not to make this sort of a scary slide, but it's just the idea that diabetes can affect all parts of the eye. Essentially, diabetic retinopathy is the thing that we screen for and that we care the most about. And that is essentially there's a non-proliferative stage, which is a non-bleeding stage in terms of new blood vessels, and there's a proliferative stage. There's diabetic macular edema, which we'll also get to in a moment. Cataracts, everyone develops cataracts as we get older. That's when the lens inside your eye, the natural lens, starts to get cloudy as we get older. And that happens earlier in patients with diabetes due to multiple reasons. Glaucoma, also another very common eye condition, but can happen in diabetes, especially when the new blood vessels inside the eye start to clog up the drainage channels of the eye. And then all sorts of other complications, which are sort of related to the ones that we just spoke about. And so diabetic retinopathy is the leading cause of blindness in working age people in the US. Even in patients who, do everything right, they may benefit from some type of surgery. But really our goal is not only to treat the eye, but is to treat the underlying condition and to work with our endocrinologist to make sure that your blood sugars are okay, that you're controlling your blood pressure and other modifiable risk factors. In terms of how diabetic retinopathy forms, this is sort of a busy slide, but essentially there's high blood sugar that this persistently elevated blood sugar starts to affect the blood vessels in the back of the eye. So just like diabetes affects the blood vessels throughout the body, there are a lot of blood vessels in the back part of the eye, in the retina, which is like the film in the camera, and that's the part of the eye that gets affected the most by diabetes. What happens over time is that these blood vessels continue to get damaged and they may start to leak out fluid. So, think of these like pipes, the blood vessels or pipes that are carrying blood throughout the back of the eye. And as they get weaker, they start to have all these leaks, and then fluid can exit from these blood vessels, and that can start to cause swelling, or it can start to affect the vision right in the center. And because there isn't great blood flow within these damaged or leaky pipes, the retina is craving oxygen. It's not able to function as well as it needs to because it requires so much oxygen, and that leads to all sorts of molecules being sent out, including VEGF or VEGF, and that stimulates new growth of blood vessels, or it stimulates even more swelling of these blood vessels that in terms of leaking out fluid, and that causes issues with the vision, which we'll go into sort of the different parts of it. But that's kind of the lay work of diabetic retinopathy, of why the blood sugar causes damage to the back of the eye. And so symptoms, it in the initial stages, it may not actually cause too many changes to the vision, which is why it's so important to do screening, because there could be changes related to the diabetes, but it may not cause any vision changes. And what we like to do is to see patients and follow them before vision changes happen so that we can be proactive about anything that needs to be treated. Usually there's no pain whenever there are changes to diabetes, except for perhaps the later stages, and including vision changes, again, could be in the later stages, and that those vision changes could be distortion of vision, blurriness of vision, or even dimming of the vision. And by then, we would have hopefully already seen you and be able to prevent a lot of these things. And so when it comes to screening and monitoring, if anyone who's diagnosed with diabetes, we typically like to do a yearly exam. So if a patient comes to our clinic and we examine them and there's no signs of diabetes in their eyes, then they're doing a great job, and we say, you look great, we'll see you in 1 year. And we just do that every year. We check to make sure that there's no changes related to diabetes. If we start to see some mild changes, that's okay. That's, we would call that a sort of mild retinopathy. And we just see the patient a little bit more often. So we would see them anywhere from 6 to 9 months. And there's no treatment that's required at this stage. We just continue to follow, but we happen to follow a little bit more often just to make sure that if there were some mild changes that can require treatment, or if it affects the vision in any way, we're able to catch it on the earlier side. And then if retinopathy becomes more severe, then we may see even more often every 4 to 6 months. And then if it's severe to the point that it's either causing bleeding or if it's causing swelling to the retina, anything like that in the milder stages, of severe retinopathy, then we would treat or follow every 1 to 3 months. So it's very personalized. It really just depends on how severe the condition is, what your symptoms are, and we have such amazing imaging in our retina clinics that we're able to really see some very subtle changes, more so than even 5 years ago. So it's very exciting what we're capable of doing. In terms of diabetic retinopathy, there are sort of two baskets that we think of. One is non-proliferative diabetic retinopathy. So proliferation means growth of new blood vessels. So in diabetes, there are early stages that we call non-proliferative diabetic retinopathy. And in the later stages, it can be proliferative diabetic retinopathy, in which the blood vessels are so damaged that new blood vessels need to be formed. The retina is essentially screaming for oxygen. So it tries to make up for it by growing new blood vessels. But the downside of these new blood vessels is that they can bleed. And so that can cause all sorts of issues. And so that tends to be the later stage in which we have treatment for it. There's also diabetic macular edema. That's when the blood vessels, specifically in the center of the retina, are also damaged and they can leak out fluid and cause a distortion in the shape of the retina in the center. And that causes blurry vision right in the center. And so for treatments, there's Dr. Hussain is going to go into a nice portion of today's series in which he'll discuss the systemic treatment and the advances in that side. From the eye side, we really do have fantastic treatment options. What I like to tell all my patients is that, even though there's so many visits that you have, you're seeing an endocrinologist, your primary care doctor, maybe a neurologist, a cardiologist, a nephrologist, et cetera. I totally empathize with how much burden that is to be able to see so many physicians. But I will say that as long as you come to the retina appointments and as long as you show up and as long as you're amenable to our treatments, I promise you, you will not lose vision. And so that's the faith that we have in our treatment options with laser and eye injections, in which we can really, really prevent you from losing vision. So as long as you come to all the appointments, and then we have the opportunity to treat you, you will not lose vision. And so this is just a schematic of the normal eye. This is the front part of the eye here, and then the back part with this line here, this is the retina. And so think of the eye like a camera. Light enters through the front part of the eye. It gets focused on this lens, which this lens is what can become cloudy as we get older. Those are called cataracts. And then the light rays enter and hit the retina in the back here. It converts into an electrical signal, and that gets carried through the optic nerve, which takes us to the back of to the brain and so forth. And so this is a picture of a normal retina. This is the right eye. This is that optic nerve that I had mentioned, where we see the tip of the optic nerve as it enters the eye. And all of these red lines are the blood vessels. And so when we're looking carefully on our examination, we're looking to see, is there any change in the blood vessels? Are there any blood spots? Is there any bleeding? Is there any swelling? And so that's the main portions of our exam. In patients, when we start to develop some changes, this is called non-proliferative diabetic retinopathy. You can see the nerve here. This is a normal or healthy looking nerve. But now you can notice that there are all these little red dots everywhere throughout the retina, and these are hemorrhages or little blood spots. And that signifies that there are now changes to the blood vessels, which is called diabetic retinopathy. Sometimes when the blood vessels leak out fluid, they can leak out a little bit of fat and lipid, and that's what these little yellow dots are here. So this is, maybe moderate to severe non-proliferative diabetic retinopathy. We can get a fluorescein angiogram. So sometimes, to really understand how good the blood flow is in the back of the eye, we do a dye test where we inject a dye into your arm, and that dye travels up into the eyes, and that highlights the areas of damaged blood vessels, which you can see, for instance, in this area here, it looks a lot darker and less and more black than some of the other areas that are a little bit more gray. And that suggests that there's not great blood flow in the tiny blood vessels within this area. And then the very smudgy areas that look kind of like a smudge on your glasses. There's a dye that's lightly leaking out of the tiny blood vessels because it's not doing very well. Those blood vessels are damaged. So we get a lot of information from these types of scans. Some of my favorite scans are what we call OCT. So if you've ever seen a retina specialist or even a general ophthalmologist, If you have diabetes, we'll often get that scan, and I think of this as being the center part of the retina. Think of the retina like a nine-layer cake, and we look at all the different layers within the retina. And this looks normal here, but then if there's swelling in the retina, then it starts to develop these black spaces. So these black spaces are fluids, and we call that diabetic macular edema. When we do treatment, there are a couple of different treatment options that we have. The most common ones are intravitreal injections. So vitreal means the vitreous, intra means we're injecting into this vitreous cavity right here. And there's a space in the eye in which it's a very safe area where we can apply a needle and then we can inject treatment or medication directly into the eye. That's the incredible thing about our eye treatments is we can administer the medication directly to the eye with a very low risk of any systemic absorption. And so we can apply a large amount of medication right where we want it. As scary as this sounds, I tell patients that these injections are not as bad as one can imagine. They sound terrible, but we numb up the eye so that you're comfortable. They're very safe. We do, several dozen a day. And these really have been a game changer in many of our retinal conditions in which there can be significant vision loss if not treated. And so you may see on television, there are all sorts of brands or types of injections in which they're advertising. This is all based on the molecule that blocks VEGF that we had talked about earlier. So these are called anti-VEGF medications. We've been injecting these types of medications for 20 years. And in the last 20 years, we're just continuing to have new medications that come out onto the market that are more durable. So Avastin, which was one of the first medications used, is an extremely, extremely effective medication. It does like 90% of the job. And then in some patients, sometimes that may not be enough. For several patients or for the majority of patients, that is enough. But let's say for the patients in which that may not be strong enough, then we have all different types of branded injections that may be able to provide a little bit more strength for patients, especially if we have to treat very often. Then sometimes some of the stronger medications can allow us to space out the interval between the injections so you don't have to come as often. We can also inject a steroid into the eye. So the anti-VEGF class is our first line treatment. But if patients do not respond to the anti-VEGF, then we have a couple of more options in our toolbox, and that's usually with steroid. And there are a couple of different ways we can administer that steroid. Some of them are just injecting the steroid directly in sort of a solution, and sometimes they can come in the form of an implant that also works quite well. And this all totally depends on the individual patient on how they respond. So I wanted to give a case example of a patient just to show how incredible these medications are. On the left side of the screen is a patient that has had no treatment. So they have pretty severe diabetic retinopathy. They have hemorrhages or blood splotches all throughout the retina. You can see all these red dots here. The blood vessels are not very healthy. So I would imagine if we looked at an OCT, there would be some swelling or diabetic macular edema here. There may be some new blood vessels that have grown. And so this is a patient that warrants treatment, and there's all these different treatment regimens on how many injections we give. And again, that depends on the patient. And you can look a few years later, all the hemorrhages or blood spots are gone. In this particular case, the patient's vision improves significantly. And so that's kind of what I was getting at earlier when if we are able to give the treatment works so well, but we have to make sure to catch it on the earlier side because if we catch it on the very advanced stages, and that's when we usually have to do surgery, and that's when the visual outcomes can be less predictable. And so this is a patient with proliferative diabetic retinopathy, in which they have new blood vessels that have grown, and we're pointing out a small net of new blood vessels, and these red streaks are actually blood in the gel part of the eye in the vitreous cavity, and that signifies that there have been new blood vessels that have bled, and so we call that proliferative diabetic retinopathy. This patient was scheduled for laser, but they weren't able to make it for various reasons, and so this started to fill with blood, and those new blood vessels bled even more, and of course the vision dropped because we can't see into the retina, the patient cannot see out of the retina. And so, that is the patient's very symptomatic. We can do an ultrasound if we don't have a good view of the retina, and that can show these white opacities or white dots, and that's also consistent with blood in the eye. And so, this is a case example of a patient. Their vision is 20/60, and they have these large areas of new blood vessels. If you can tell on the screen that they look like kind of nets or fans of red lines, and that's abnormal. That's not how it should be. The patient ended up needing laser, but for various reasons, they progressed with some laser, but they may not have come to all the appointments, and so the disease continued to progress, and there's starting to be some scar tissue that forms on the surface of the retina, and you can see the retina looks much less normal than it did in the previous images. But with surgery, we have amazing retinal surgical techniques where we can use tiny forceps and tiny instruments to be able to peel off the scar tissue. We can apply laser everywhere. And so this is a picture of a patient who underwent surgery, and it looks so much better than what it did before. So we do have a lot of options. We don't like to get necessarily to that stage in which there's a lot of scar tissue that's formed. And so that just stresses the importance of screening and coming to the appointments earlier. Because if we were just to do the injections at an earlier stage or laser, then we might be able to prevent needing to undergo surgery. And so just to summarize, diabetic retinopathy, it's an eye disease caused by diabetes. It naturally affects the blood vessels in the retina. Again, there are many stages to it, and it does not need to be a scary condition because we can be with you every step of the way. We just need to see you on the earlier side. There are several risk factors Dr. Hussain will get into. And initially, patients may not have any vision changes at all. They can be completely asymptomatic, which is why the screening is so valuable. And in later stages, there can be significant vision loss. But again, we won't let you get to that stage as long as we can provide the treatment. So getting your annual dilated eye exams, being receptive to treatment options if you ever get to that point, and then just staying informed about your health and your diabetes and treating it as best you can with our endocrinology colleagues. So that is all we have. I wanted to just kind of highlight the retina division. At UC Irvine, the Gavin Herbert Institute, we have just some wonderful colleagues of mine that are retina specialists, including our chairman, Dr. Cooperman, Dr. Andrew Brown, Dr. Stephanie Liu is our division chief, Dr. Mithil Mehta, myself, and then Dr. Mohammed Riazi.
Good evening, everybody. My name is Hussain. I'm in the Division of Endocrinology at UCI. And I'm going to be talking about nutritional management of diabetes mellitus, or diabetes, as we call it. And this is going to be about nutritional management only. I'm not going to be talking about pharmacotherapy and all the other things that we can do. This is going to be focused on nutrition. And it's a huge field. There's been a lot of new development in this area, and I'm going to highlight some of those new things that are actually very exciting, and I hope that they'll be interesting to you. So first, I'll start off with a brief overview of what we know, and then some recent insights. And those are 3 points that I'd like to already mention to you right now: that there's high interpersonal variability in blood sugar control to identical meals. So there's variability among individuals, and a personalized approach is something that we have to think about more than we've been doing until now. And then there's this entity called prediabetes, which can be reversed with diet, and through that, diabetes can be prevented. And this can be done with diet or lifestyle changes alone, without any medications. And the third thing I want to point out to you is that there's this new way of putting diabetes into remission. And we define that similar to what cancer patients already know as being in remission, is that the disease is no longer detectable. It's not that they're cured, but the disease is no longer detectable, and they go without treatment or without medication and have no sign of diabetes, which is very exciting for us. And this can happen, this can happen through nutritional management and some lifestyle changes only. So I'll talk a little bit about these new developments towards the end. So essentially, when we eat, most of or half of the calories that we eat is mainly carbohydrates. and they are broken down in the intestine to sugar, and that sugar enters the bloodstream. and and our body, what it does is the pancreas responds to that with the high sugar that's coming into the blood, and the hormone insulin is released from the pancreas, and this insulin helps transport the sugar from the blood into our cells, and the sugar that goes into the cells is used as energy. And so in someone with diabetes, on the right side of this panel, you can see that the insulin that is made is not enough for the body to put all the sugar away into the tissues. And the absence of insulin, the blood sugar is unable to enter the cells, and the blood sugar levels stay high. And that high blood sugar is what damages other tissues, including the retina that we heard about today. So it's this high blood sugar that occurs because there's not enough insulin. That's one thing, but the insulin also can't work at its tissue, and that's called insulin resistance. So the tissues in the body become resistant to insulin, and the insulin that is produced in the pancreas is not enough to overcome that insulin resistance. So there are two mechanisms at play here. And if you look at what happens with your blood sugar when we eat, that after breakfast, blood sugar goes up, and the dark curve on the top left shows us what a normal blood sugar looks like. Blood sugar goes up and then comes down because insulin brings the blood sugar back down. And then at lunch, the same thing happens. And at dinner, the same thing happens. The blood sugar goes up and is brought down back by insulin. And the gray line, or the lighter line, shows somebody who's diabetic. The blood sugars are always elevated, and they still go up with meals. They just don't come down to normal levels. There's something that we see early on in diabetics, and that is that the blood sugar might go up quite a bit after a meal, and then the pancreas responds to it with producing a lot of insulin when the pancreas still can produce insulin. So this is typically a patient who's insulin resistant or on the way to becoming diabetic. And they produce so much insulin that it actually rebounds and brings the blood sugar down very low, actually even to levels that are considered dangerously low. And that we call that a roller coaster blood sugar. So it goes up and down. And this can happen in patients who are going to become type 2 diabetics in the following few years. So we see that as an early manifestation of people who are on their way to becoming diabetic or are at risk of becoming diabetic. So essentially, there are two mechanisms at play. One is on the left side, the insulin secretion from bottom to top over here. So insulin is secreted depending on how much is needed in the blood to respond to the blood sugar. And this is insulin resistance or insulin sensitivity. So on this side here, we have a very insulin sensitive individual, somebody who's exercising and has very little fat. You can see this is an insulin sensitive individual, and their blood sugar is going to be normal. And on this side here, we have Mr. Couch Potato, and he's very insulin resistant. And this insulin resistance comes with obesity, and insulin sensitivity is affected by exercise, and diet can go both ways depending on what the diet is. Normally, if somebody becomes insulin resistant, that means moving to the left on this graph, then their insulin production increases. So it goes from point A to point B, for example. This can happen to all of us. Let's say we're bedbound because we have the flu and we can't move around. Within a few days, we become insulin resistant, and our body responds to that by making more insulin to control the blood sugar. And those people who become diabetic, they have the problem that their insulin production cannot cope with the insulin resistance that happens, and then they have something called impaired glucose tolerance. That is, we call that prediabetes. And if it gets worse and the beta cells cannot make enough insulin in the pancreas, then the blood sugars become very high, and then we have type 2 diabetes. So this is kind of how the mechanism or how the body controls its blood sugar, even when even when we become ill and lie in bed, can't move around, cannot exercise, the body can cope with that unless it has problems with making insulin. This part is something that the body responds to with insulin production in the pancreas. This is something that we can control very well. We can exercise or we can influence our insulin sensitivity to diet. This part, the body produces insulin on its own, and this part we can influence with pharmacotherapy to help the pancreas produce more insulin and move this point C to point B or further up the curve here so that blood sugars are controlled. Now, with medical nutritional therapy only, with just diet or dietary intervention, hemoglobin A1C can be reduced by about 2%. And if you see here, this is the risk of retinopathy, this graph up here, the risk of retinopathy, and you can see how the risk increases with the hemoglobin A1C. So if you imagine you have a hemoglobin A1C, which gives us an estimate of how high the blood sugar was in the last 3 months, if you have a hemoglobin A1C, your relative risk of developing retinopathy is more than 10% per year, right? And just with nutritional therapy, you can bring it down by about 2 points to 9, and then you're below 5%. So you can halve your risk. Or if you have a hemoglobin A1C of 9, your risk is maybe 5 to 6%. And if you bring it down to 7, it's below 3% or nearly 2%. So significant changes can be brought about by medical nutritional therapy. And you can see that retinopathy here is the one that responds most favorably to dietary intervention, and is the one that is also at higher risk of developing with high blood sugars. Now, there are 4 concepts that we think about when we're talking about nutrition and nutritional management in diabetes or any metabolic disease. One is carbohydrates. There are fast versus slow carbohydrates, and these determine blood glucose excursions. So the high sugar peaks after a meal happen when you have fast carbohydrates in your diet. When you have slow carbohydrates, then those blood sugar spikes are not as pronounced, and that helps with the blood sugar control. There are saturated lipids or fats. Those can cause insulin resistance. So the part that affects how well insulin works on the tissues. And there are also risk factors for arteriosclerosis, leading to heart attack, ischemic, or stroke, or peripheral artery disease. Then there's salt. High salt content leads to high blood pressure, and that can affect arteriosclerosis as well, and hypertension or high blood pressure can affect insulin resistance. And so and overall calories can lead to increase in weight, and that excess calories that we eat is stored as fat, and fat tissue causes insulin resistance in the rest of the body. So increased fat tissue causes the liver to be resistant to insulin, cause muscles or skeletal muscle to be insulin resistant, because the fat tissue secretes substances that affect how insulin works in other tissues. And so these are the 4 things that we look out for in nutrition, and how nutrition could be managed, or how these things can be tweaked to adjust to help people with diabetes. There's 2 diets that I want to point out to you that I think are most effective. One derived from the DASH diet. DASH stands for Dietary Approaches to Stop Hypertension. And there's a version of it that was developed called DASH 4D. And that is Dietary Approaches to Stop Hypertension for Diabetes. And essentially, it's low in salt. It's rich in fruits, vegetables, whole grains, low-fat dairy products, lean proteins, so less fat in both of these. These are slow sugars, not fast sugars like in sugary drinks, and no fast carbohydrates, so no sugary drinks. So this is essentially what the DASH 4 diet essentially contains, and it's very effective. Like I said, with diet, you can change your hemoglobin A1C by 2% points, and that is quite significant when it comes to retinopathy. And this is how the different meals look like in a DASH4 diet, lower sodium diet. So there are these different components or different examples of what a meal can look like, and this is these are examples of what a traditional meal looks like, and how the comparison between these two different diets. So this is the one that is recommended for managing individuals with type 2 diabetes, especially the ones who have high blood pressure. And you can see here, this is a study that was done in people with the comparison diet and the DASH for diabetes diet. And you can see the blood sugar levels over 14 days measured is always lower in these individuals. And if you look at the blood sugar levels during the day, the blood sugar levels are also lower in the individuals who have the DASH4 diet, 4D diet. The other dietary intervention, or the other type of meal that I think is very useful to understand, is the Mediterranean style eating. And sorry, I don't, this has been moving on too fast. The Mediterranean diet style contains very much similar components like the DASH4 diet. It has a lot of olive oil-based fat, and it also has grains, fruits and vegetables, legumes. Slow carbohydrates is important. It's not limited in calories as much as other diets that we have here. There's alternate day fasting. There's an approach of diet fasting on 2 different days during the week. This is alternate day. And then there's time-restricted eating. These are very difficult to maintain diets. These are very effective in losing weight, in controlling blood sugar, but they're very hard to maintain for people. And the Mediterranean diet, in contrast, or the DASH4D diet, are easy to maintain and adjust to, and people can stick to those diets much longer. And so, as a summary of this overview that I just gave you, is that nutritional management essentially starts before the diagnosis of diabetes. And we have 2 components. We have the risk of developing diabetes, and that is mainly at the level of the pancreas and the insulin production. We cannot do much for that with nutritional intervention. We can do something with drugs and pharmacotherapy and increasing the insulin output. On the other side, we have lifestyle, which essentially is exercise and nutrition. And in terms of nutrition, we think about the food choices, and then the calories. The calories meaning how much calories are we taking in? Is it too much? Is it leading to obesity and insulin resistance? Food choices such as fast and slow carbohydrates, saturated fat or unsaturated fats. How much protein? What kind of protein is it? Is it lean protein, or is it protein with the large amounts of saturated fats? So this is where we can do something about with nutrition without pharmacotherapy. We can change insulin sensitivity or insulin resistance with pharmacotherapy as well, but there are not many drugs available for that. The mainstay of influencing insulin sensitivity or insulin resistance is nutrition and exercise. And this is actually the first thing we do for diabetes, or even before diabetes, to try to help people prevent the development of diabetes. So now let's go to the important new insights, the new developments. What I just mentioned to you is that nutrition in diabetes is very effective in reducing hemoglobin A1C, and we just talked about that. And the next points that I'm going to make are relatively new and very important. So there's interpersonal variability between individuals, and I'll talk to you what I mean by that, in post-meal blood sugar. So there's a large variability between people, and when they eat a meal, their blood sugars can respond very differently. And we'll get into that in a little bit. The nutrition management starts before diabetes diagnosis, and there's something called prediabetes, and prediabetes can be reversed with dietary intervention without weight loss. And so just by modifying what you eat, you can reverse prediabetes or bring prediabetes into remission. And the last point that I'm going to make is that type 2 diabetes remission is achievable with dietary intervention and weight reduction. So you can get into a situation or into a metabolic state where you actually don't have detectable diabetes. You've been diagnosed with diabetes in the past, but with dietary intervention and weight reduction, you can actually get into something that we call diabetes remission, something that's similar to what we know from cancer. When somebody's in remission, that means cancer-free, not cured, but free of cancer. We say they're free of diabetes. They're not cured, but they're free of diabetes. They don't need any medications to control their blood sugar. They can maintain or control their diabetes without that. So let's get to the interpersonal variability. So there was this is already a decade old, but there was this very important study which still reverberates to the field, is that there's this banana and cookie test. So they gave two different people, a banana to eat and a cookie to eat. And you can see this person, the banana didn't do much to the blood sugar, but the cookie raised the blood sugar a lot. This person ate a banana and the blood sugar went way up, and the cookie didn't do anything. And this turns out to be true. If you look at hundreds of people, which these people did in this study, they saw that there was large variability among individuals. And you can see here that these are the participants, or this is the blood sugar, and different people had different excursions of blood sugar responding to a standard meal that these people were given, that these investigators gave these individuals. And so you can see here participant number 67, 663. So they tested close to 900 people, and they can see that the blood sugar levels can be nearly flat in response to a test meal, or very high in response to the same test meal in a different individual. So there's large variability. So how can we deal with this variability when we want to control blood sugar and manage diabetes with nutrition? And it turns out there's no clear good method for predicting individual post-meal glycemic response to food. So there's no test that we can do to figure that out. And there are multiple factors that influence the blood sugar after a meal in any given individual. And so what is possible, though, is that you can give individuals different meals and measure the blood sugar afterwards. So and then you figure out which are the good components and which are the bad components for this individual, and which are the good components or bad components for another individual. And there actually are now methods or apps that are available where people can be given test meals, a variety of test meals, and then their blood sugar can be measured. And this app can then determine what type of nutrients or what type of food items will be beneficial for an individual, but might not be beneficial for another individual. They might have another set of nutrients that or meal choices that they would have to make to control their blood sugar. So this individual variability, or this personalized approach, is going to become more and more important as we move along and become more sophisticated in our dietary regimen. So this is very different than telling everybody to take a DASH4D diet or telling everybody to take a Mediterranean diet. So this is more personalized and more individualized. And it's something where electronics and artificial intelligence and computation will help us guide, make our recommendations and guide people. So moving on, I want to talk a little bit about prediabetes. And that is a hemoglobin A1C that's between 5.7% and 6.5%. Or 6%. So diabetes is when the hemoglobin A1C is higher than 6.4. And in the US, prediabetes is between 5.7 and 6.4. In Europe, it's 6.0. So in America, we're a bit more stricter with when diabetes starts or when prediabetes starts. And like I showed you before, retinopathy and other complications of diabetes heavily depend on how high your hemoglobin A1C is, right? And so let's talk about prediabetes, we're down here. We're talking about this area down here. And it turns out that, and so prediabetes has a risk of 5 to 10%, per year in any individual to become diabetes. And the lifetime risk of somebody who has prediabetes to become diabetic is 74%, so very, very high. But it turns out that prediabetes is already a risk factor for macrovascular disease, not for microvascular disease like retinopathy, but macrovascular disease like the vessels around the heart, or the vessels that go to the brain, or the vessels that go to the legs. Those are larger vessels, and arteriosclerosis in those vessels already occurs at a higher rate when individuals have prediabetes. They don't have to be diabetic, but even with prediabetes, they have this higher risk. And it turns out that you can, with dietary intervention or with nutritional intervention, you can get into a state called prediabetes remission. So you can move into this direction. There's pharmacotherapy as well, but there's actually also dietary or nutritional intervention. And after I've talked about the prediabetes remission, we'll look a little bit more into diabetes can also become a state of diabetes remission. So we're not talking about diabetes moving to prediabetes, but diabetes moving to a state where diabetes or prediabetes is no longer present. And this is mainly achieved by about 15% weight loss and managing the weight at a level that stays low at that point. And so we can remove this risk from prediabetes moving to diabetes by causing prediabetes into a remission state. And you can see here, this is a trial that was done published just recently. You can prevent type 2 diabetes through prediabetes remission without weight loss. So this was an intervention where the individuals did not lose weight, so they did not have to eat less calories. They just had to modify what they were eating a little bit. And this was done in a very strict scientific way, in a randomized controlled way. There was a lifestyle intervention, which included exercise and diet. And this diet was very similar to the Mediterranean diet that I just pointed out to you earlier. And you can see here the people who did not, who were the controls, who did not get this intervention, their progression to type 2 diabetes, or this is the absence of progression. So this curve, the lower you are, the more you're diabetic. About 60 to 70% of the individuals after 10 years were diabetic, who had started off as pre-diabetics. So the 74% risk from going from pre-diabetes to diabetes holds true in this cohort. And the people who had this intervention while they were pre-diabetic, this is how many actually progressed to diabetes, or how many stayed free of diabetes. So nearly 90% were free of diabetes even 10 years later. And this was just by changing what they were, the contents of the food that they were eating, not even reducing the calories, right? And this is the last point that I'm going to make today, and that is that there's something called diabetes remission. And you can move from diabetes to diabetes remission. And this happens after approximately 15% weight loss through lifestyle intervention. And so this is a trial that was done in England. The individuals got a formula low energy diet, and then afterwards they had food reintroduction. So this was 12 to 20 weeks. They lost weight, and then they were reintroduced to normal tasting food. This was a formula that they got. Then they got normal food, and the goal was to maintain their weight loss up to 52 weeks. And diabetes remission was defined as hemoglobin A1C below the diagnostic threshold, and in Europe it's 6%. And there was no evidence of type 2 diabetes for more than 6 months without any other treatment, so no other medications, right? And 46% of the individuals who participated had remission overall, and 61% remission was found in the intervention group, 12% in the standard care group. When you look at the overall weight loss here, 15% weight loss was achieved by a small group of people, a relatively small group of people. 5% weight loss was achieved by a larger group of the cohort. There was another follow-up study that was published just recently, and you can see here 61% had remission in the intervention group in this trial as well. And they also had a reduction in their weight and hemoglobin A1C, which stayed low. And they were in remission after a period of, this is also after a year. So this is an exciting new development. It's possible in a large age group, so between 18 and 50-year-olds were included in this trial. And the people who were most successful, the people who were had recently been diagnosed with diabetes. So this is something that we also have learned now, is that people who haven't had diabetes for a long time, these interventions are particularly effective. So it's very, very important that that one does not go on for too long before getting into these type of nutritional management programs, so that the earlier you intervene, the better the outcome is with achieving remission and being free of diabetes. And free of diabetes also means that you also don't develop the complications like retinopathy and other microvascular complications that we know about in diabetes. And so to close off, the summary of important new insights that I told you about is nutrition in diabetes is very effective in reducing hemoglobin A1C. There's high interpersonal variability in blood sugar control, and there's much more to be done and learned here. And how we approach nutrition is going to be very important at the individual and personalized level, right? Nutrition management starts before diabetes diagnosis, like in prediabetes. And prediabetes can be reversed with dietary intervention. And lastly, very exciting, type 2 diabetes remission is also achievable with dietary intervention and weight reduction. This weight reduction is kind of well known already with bariatric surgery. That is something that reduces weight by surgical means, where a large amount of weight is lost, and those people can actually become diabetes free if successful. And so the future outlook is going to be the individualized nutritional interventions. There's also going to be an integration or combination of these newer weight loss medications that everybody's talking about, the GLP-1 receptor agonists, to induce the weight loss and diabetes remission, and then find ways of removing this treatment as well to remain diabetes free without medication. So those are the new developments that we're going to be looking at very carefully and trying to implement that into our patient care. So thank you very much. I hope this was informative to you.